Good morning. So the next topic for discussion is on metabolic alkalosis, in which I'll be talking about introduction, etiology, and management. Now, this topic is important both from a theory perspective as well as from a practical perspective. So we need to know well in depth about this. So coming to the introduction, metabolic alkalosis is defined as an increase in the bicarb concentration in the extracellular fluid with values usually being more than 26 milliequivalents per liter. So coming to the etiology, it can be because of intracellular shifts of hydrogen, which is commonly associated with hypokalemia. So what happens is that potassium depletion causes potassium to move from within the cells into the extracellular fluid. So this transcellular potassium flux causes extracellular hydrogen ions to move from out of the cell into the cell. That is from the extra cellular space into the intracellular space to maintain electrical neutrality. Next, gastrointestinal hydrogen losses also can lead to metabolic alkalosis, which is more commonly seen with upper GI sources like vomiting or nasogastric suctioning. So, in these two conditions, there can be loss of gastric secretions, which are rich in hydrogen, chloride, and to a lesser extent, potassium. So, hydrogen losses initiate metabolic alkalosis, whereas chloride and potassium losses will sustain the metabolic alkalosis. With regard to lower GI etiology, diarrhea can cause metabolic alkalosis, though it is more commonly associated with metabolic acidosis due to loss of bicarbonate. But in scenarios like Willis adenomas or use of laxative abuse, metabolic alkalosis can be seen, which is normally attributed to hypokalemia. So hyperkalemia leading to metabolic acidosis has been explained in this, where it is because of intracellular hydrogen shift. Third cause of metabolic alkalosis can be because of post-hypercapnic alkalosis, where chronic respiratory acidosis, especially seen in COPD patients, increases the renal H plus secretion, that is in the form of ammonium chloride loss with bicarbonate reabsorption. So, this ensuing rise in bicarbonate concentration will help to return the pH to the normal levels. Just emphasize this point once more because it has more of practical implications. In patients with hypercapnia, like in COPD patients who eventually develop chronic respiratory acidosis, for the pH to compensate, there will be an increase in the renal H plus secretion in the form of ammonium chloride loss, and there will also be increase in the bicarbonate reabsorption. So these two factors help to maintain the pH within the normal limits. In conditions where there is excessive renal hydrogen loss, there can also be alkalosis because the increase in H plus loss will lead to an increase in the bicarbonate within the body, which is commonly attributed with loop and thiazide diuretics. These promote alkalosis via loss of potassium chloride and H plus ions, and Bartter and Gentleman syndrome, which are supposed to be genetic defects in ion transporters, will have an effect similar to loop and thiazide diuretics. Bartter will have a loop diuretic-like effect and Gentleman like a thiazide diuretic-like effect. And mineralocorticoid excess in the form of Conn's or Liddle syndrome can also enhance potassium secretion in the distal tubule via direct stimulation of the secretory H plus ATPase pump, increase in the number of open ENaC channels, and increase activity of the sodium potassium ATPase pump. So, mineralocorticoid excess in the form of Conn's syndrome, Bartels, Gentleman, loop, and thiazide diuretics. All these can lead to metabolic alkalosis. So one of the most common causes of metabolic acid alkalosis that is seen in the ICU is contraction alkalosis. So it occurs when there is loss of relatively large volumes of fluid, that is plasma, that has a high sodium chloride content and a low bicarbonate concentration. So the plasma bicarbonate increases in this setting as there's a contraction of the extracellular volume with chloride depletion occurring simultaneously. So this is commonly seen in patients on loop diuretics to induce rapid fluid volume removal in markedly edematous patients, especially in patients who have been initiated on deresuscitation or in patients who have been very aggressively treated for cardiogenic pulmonary edema. And the last cause is due to alkali administration. Under normal circumstances, short-term administration of large amounts of the sodium bicarbonate usually leads to rapid renal elimination of the entire alkali load with minimal increases in the bicarb concentration. But in the setting of hypovolemia or reduced effective arterial blood volume like in heart failure or impaired renal function, with simultaneous administration of sodium containing organic ions like lactate, citrate, and acetate, metabolic alkalosis can occur. So, with regard to the management, in the clinical features, usually most patients will be asymptomatic, though those who are conscious may elicit fatigability, muscle cramps, or postural dizziness. A postural dizziness can be because of hypovolemia that is present in the subset of patients. So the diagnostic evaluation is based on the following tests. You need to look into the urine chloride, urine potassium, and arterial BP. So these are the main prerequisites for evaluation of metabolic alkalosis. So if the urine chloride is less than 20, it means that they are chloride or saline responsive. So that is usually associated with volume contraction states like diuretics, GA loss like vomiting or NG suctioning, laxative abuse, or congenital chloride diarrhea. Whereas if the urine chloride is more than 20, then they are going to be chloride unresponsive. In these cases, we need to assess if the urine potassium is low or high. So if the urine potassium is less than 20 milliequivalents per liter, then it indicates prior diuretic use, villus colonic adenoma, or severe hypokalemia as the cause of metabolic alkalosis. Whereas if the urine potassium is more than 30, then you need to check the BP. So if the BP is low or normal, it can be used attributed to gentlemen's or Barters, high dose sodium bicarbonate infusions, diuretic overuse that will be ongoing. Whereas if the BP is high, then you need to look at the renin levels. So if it is low renin, it is Conn syndrome. Normal renin, it is Cushing syndrome. Or high renin, it might be malignant or renovascular hypertension. So this is one of the best ways of working up for metabolic alkalosis. So the important three parameters to look into is the urine chloride, urine potassium, and the BP. So coming to the treatment, the most important thing is to treat the underlying cause. For example, you treat the cause of vomiting, stop or reduce the removal of gastric secretions. If it is possible, stop loop and diacid diuretics. And if severe hypokalemia is present, you need to supplement it intravenously, with potassium chloride. And if hypomagnesemia is a big suspicion, then magnesium supplementation should also be done. In cases of a chloride-sensitive metabolic alkalosis, that is, if the urine chloride is less than 20, it must be most likely because of fluid depletion. So since metabolic alkalosis is primarily the result of chloride and potassium depletion, the net loss must be replenished to correct the alkalosis. That can be done with the use of isotonic saline and potassium chloride. So IV correction plus or minus magnesium correction should be done. So in regard to the saline infusion, the volume of isotonic saline needs to be calculated to correct alkalosis. So the formula is usually given as follows. The first step is to estimate the chloride deficit, which is given as 0.2 into body weight into 100 minus plasma chloride. So once you estimated the chloride deficit, you need to determine the replacement volume of saline. So that deficit needs to be divided by 154. Then, based on this volume of replacement that is calculated, you keep the rate of replacement that is usually kept at 100 to 125 ml per hour. Now, it would be really difficult because from an exam perspective, it would be difficult to remember all the formulas. In the exam, if this question is kept and you suddenly are out of an idea for the formula, just mention that the rate of replacement is kept at the rate of 100 to 125 ml per hour with regular monitoring of the hemodynamic and the fluid status using point of care ultrasound. In enigmatic states, isotonic saline is contraindicated as they are redistributed mainly in the interstitial compartment. So in these scenarios, it is ideal to use a potassium-sparing diuretic like spironolactone or and acetazolamide as a single dose, repeated with another dose based on the acid-base status. So usually we give acetazolamide about 200 to 500 milligrams first, and then based on the acid base, you do a repeat ABG, assess the bicarbonate levels, and then decide the next dose. So usually a maximum of 1 to 2 doses after the initial dose is usually given for acetazolamide because acetazolamide can be a cause of metabolic acidosis. So rapid correction also may be harmful. So for chloride sensitive metabolic alkalosis, it's mainly about replacement. So you replace the volume with normal saline, and if potassium losses are there, that needs to be corrected. So coming to chloride resistant metabolic alkalosis, alkalosis from mineralocorticoid excess that can be primary or secondary can cause an increase in the extracellular volume. So in these scenarios, saline infusions may be counterproductive. So hypokalemia is common in this type of metabolic alkalosis. So potassium replenishment helps in correcting the alkalosis to a certain extent. One of the two measures needs to be adopted. One is acetazolamide needs to be given. Its mechanism is by inhibition of carbonic anhydrase, which causes inhibition of bicarb reabsorption and increases the urinary bicarb excretion. So by helping removing of bicarbonate, it helps to improve the pH. Whereas in conditions where despite potassium supplementation and acetazolamide administration in chloride resistant metabolic alkalosis, there is not an improvement in the pH or in the bicarbonate, hydrochloric acid infusion can be considered. But it is a very high risk medication and it needs to be reserved only for patients with severe alkalemia with symptoms. So the dose of hydrochloric acid is given by the following. So for step 1, we need to estimate for the H plus deficit. So you calculate it with the formula is 0.5 into body weight into plasma bicarb minus 30. Then We determine the replacement fluid volume for saline in 1 liter of 0.1 N of HCl. That is given by the H plus deficit divided by 100. The next thing is the rate of replacement. The maximum rate of replacement should be within 0.2 milliequivalent per kg per hour. And it must be infused only via central venous catheter. If hydrochloric acid is unavailable, then ammonium chloride, which is available as a 20 ml vial, can be administered. This 20 ml vial contains 100 milliequivalents of more ammonium chloride. So, when these infusions are started, it is important to assess the hemodynamics, and a regular blood gas monitoring is also required. And if the target is achieved, these medications need to be stopped at the earliest because they have a high potency for side effects. So, with regard to chloride resistant metabolic alkalosis, three things that need to be kept in mind is you go with potassium replacement if it is low, then consider acetazolamide. And with potassium supplementation and also acetazolamide administration, if the alkalosis is still persistent and severe, then you need to consider hydrochloric acid infusion. If it is unavailable, then ammonium chloride can be supplemented. Thank you.